Hello everyone, Leslie Cornwell here, certified nurse midwife with Midwifery Business Consultation. This next educational section is management of umbilical cord prolapse. Objectives, defining what is an umbilical cord prolapse, understanding risk factors for a potential prolapse, being familiar with maneuvers available to help manage umbilical cord prolapse, be able to explain contraindications for maneuvers that people may try to help with umbilical cord prolapse. There's three types of umbilical cord prolapse. The occult, which is the more common one, traditionally happens more towards the end of delivery where part of the cord is getting kinked, typically by the head. It's trapped between the presenting part and the pelvic wall. I've had it a few times where the non-reassuring heart tones when you're pushing towards the end and find out that there is a cord next to the baby's head. Can occur sometimes when the water is ruptured. A cord presentation occurs when a portion of the cord is positioned beneath, below, or in front of the presenting part. Traditionally, you see this in preterm mamas that are breech, could be on an ultrasound, could be the water's broken and the forebag is still present. So it's not quite in a medical emergency, but it's pretty risky because as soon as the water breaks, the cord's going to be completely prolapsed and kinked off. So the baby at this point, as long as the water's not broken, still is getting good oxygen, no concerns, but you put them in hands and knees, you get them to emergency services right away, because if the baby is breached, the cord is down there, you can't do a vaginal delivery. You have to deliver by a C-section to make sure the baby is safe. Overt prolapse is the most extreme. It's where you can see the umbilical cord directly hanging out of the vagina with your own eyes, or it's palpable after the water has been broken. And that's the one we're more going to focus on in this presentation, is when minutes matter and the cord is being kinked, the lifeline to baby's oxygen supplies, what do you do? So we talked about the three different kinds. The occult hidden prolapse, where it's just a little bit kinked by the baby, and you notice that more towards the end with pushing, and you don't know till after the fact. A cord prolapse where it's in front of the baby's head. Usually that's with breech presentation earlier on. The water, they're not in labor yet. There's a bag. You find it on ultrasound many times. The complete cord prolapse is the worst. The water's broken. The cord is hanging out of the vagina. Sometimes you can see it, and minutes matter at that point. Incidence, it's extremely rare, thank goodness, 0.1 to 0.6%. Risk factors include a non-vertex presentation where the head is not down, so like a footling breech, transverse. It's pretty rare once the head is down. I've seen it a couple times where the water's been broken by a provider and the baby wasn't well applied to the cervix yet. But most of the time it's those transverse lies, the baby is sideways, or breech, the butt is presenting. Other risk factors, the water being broken when it wasn't ready, unengaged presenting part, so the head's not well applied to the cervix when the water is broken. A lot of fluid sometimes makes a difference too, because it'll help bring that cord down faster. Preterm labor, so it's that presenting part is not well engaged. Low birth weight, smaller baby. High gravity has to do with many babies. The uterus isn't nice and firm. The baby can not get well engaged until almost the end of the birth process. And then a mom having multiple babies. So if there's twins, you're more likely to have a sideways baby, a breech baby, just not have vertex. Low-lying placenta, it makes it harder for the presenting part to be well engaged on the cervix. Complications, it's a very serious situation. The cord is the lifeline for the baby, and if it's being kinked, minutes matter. So there's a high morbidity and mortality related to poor oxygen supply to the baby. The outcome really depends on the degree and the duration of the cord compression and the intervals between the diagnosis and delivery. So when you're in an out-of-hospital setting, it's a lot harder to have a good outcome with this situation than it is to be in a hospital setting. Either way, minutes matter. The first thing you want to do is relieve the cord compression. The baby may run out of oxygen in as little as 2.5 minutes. Minutes do matter. The longer you delay the delivery, the worse outcome the baby is going to have. And the delivery is typically a C-section. If it's an occult cord and she's had babies before, and you can just have her push through it, but most of the time it's earlier in labor, the presenting part isn't well applied to the cervix, and we just need to get the baby out by a cesarean. Diagnosis of cord prolapse is traditionally done by an internal vaginal exam. Sometimes you can find it on ultrasound. If the membranes are intact, you don't do anything. You try to keep your hands off the forebag because you don't want to risk breaking it. So if you notice it on ultrasound, your immediate action would be getting the obstetrician involved, getting the mom in hands and knees. If she's contracting, I would recommend terbutaline. Lots of education in the next plan for the mom and baby. The occult prolapse must be considered whenever the heart rate abruptly is irregular. There's variable decelerations, especially towards the end of the pushing phase. Listen to the heart tones following the water being broken. It's really important to make sure that the cord has not gotten kinked once the water bag has broken. Interventions, you immediately want to get the mom in hands and knees position. Your goal is to get the head off of the cord. Whoever is doing the vaginal exam keeps their hand in their woman's vagina and pushes the presenting part off of the cord. You don't want to manipulate and mess with the cord too much, but you can get the baby's heart rate from the cord to confirm to the team that it's still pulsating, it's above 100, it's less than 100. You are able to get circulation through the cord by pushing the presenting part off. There are some evidence about filling up the mom's bladder with a Foley catheter to help push the baby's head off, and it's rare in the hospital I've seen that done just because there's so much happening at once. They'd rather prep the OR and just get the baby out. I've seen in the hospital setting terbutaline being given to help stop the contractions, so it's not forcing the baby, the uterus isn't pushing the baby on that compressed cord. The biggest thing is keeping the mom to stay calm, trying to keep the baby off of that cord, the lifeline to baby's oxygen supply. So interventions, keeping the baby off the cord, placing the mom in a position that maximizes the blood flow. Give the mom some oxygen. The more concentrated the oxygen you can give her will help out the baby. Check the baby's heart rate as much as you can when you're limited on care providers, especially the out-of-hospital setting. Whoever is the person that has their hands in the vagina holding the baby off the cord can let you know if they're able to still feel a pulse from the cord. If the contractions are strong, we already talked, consider terbutaline, a medication, or some herbs to help with relaxing the uterus. I've heard this in theory, but I've never seen it applied. Placing a catheter, filling it up with water so that you can have a balloon helping to support the baby. And an emergency transport to a C-section is needed at this point. Minutes do matter. Positions to relieve it. The one I've seen most commonly is hands and knees, getting the mom's butt high in the air, her shoulders down, because your goal is to take advantage of gravity to try to get the baby's presenting part off of the cord. You want to take advantage of gravity, and the care provider can push the presenting part off of the cord. So if they have an epidural, they cannot move. The care provider that is doing the vaginal exam would have to push the presenting part off the cord. Important do's and don'ts: replace the cord in the vagina. So if you have a significant prolapse cord where the cord is getting exposed to the air and it's cooling, it can shrink in vasospasm. So you want to cover it in a warm, wet pad or stick it back in the vagina, but you have to be careful. The more that you manipulate the cord, you do have the chance of making it spasm. If you're able to, in a hospital setting, continuous monitoring of the baby's heartbeat. At this point, there's going to be all hands on deck prepping for the C-section room. And minutes do matter at that point. Keeping the parents well informed of what's happening. Try not to handle the cord any more than you have to. Keep pressure off the presenting. Keep the pressure on the presenting part to improve the blood flow to the cord. So if you can do hands and knees, that's the best. Otherwise, just pushing the head or presenting part so it's not kinking the cord. Try not to replace, there's no way you're going to be able to get the cord back in the uterus. It's not going to be pushed out of the way of the presenting part. You just have to prep for an emergency C-section. The only time I've seen it different is if you have an occult cord, it gets kinked when the mom's pushing. You're in the out of hospital setting, you just have her push through it and deliver a baby. So here's the different resources. Anne Fry has a great section on holistic midwifery, and especially in the out-of-hospital practice, emergency situation management. And then there's a great resource, umbilical cord prolapse, risk factors management on Teach Me OBGYN. Let me know if you have any other questions. Please send me any emails, but I appreciate you listening to the prolapse cord presentation.